Right. So maybe some of you are wondering why surgical endodontic is preferred instead of endodontic surgery. Diba? Some lecturers you may see in the future, like in PDA, the title of their lecture is endodontic surgery. But tayo, we opt for surgical endodontics. And this is the reason. Since the procedures are planned and carried out as endodontic procedures through a surgical access and not a surgical procedure done for endodontic reason. So it is generally concerned with the diagnosis and also the treatment of lesions of endodontic origin. And these do not respond to conventional endodontic therapy alone or cannot just be treated by conventional root canal treatment. So our scope of surgical endodontics is to achieve a three-dimensional cleaning, shaping, obturation of the apical portion of the roots, uh, of the root canal system, which is not treatable via an access in cavity access, but it can only be accessible through a surgical flap. Okay. So these are now the instruments or equipments that are ideal but are not necessarily required in performing the procedure or the surgical endodontics. Okay. And these can be performed even without, these can be performed with conventional armamentarium. So especially for skilled surgeon with ample experience. So the use of these instruments, equipments will not guarantee a better outcome or prognosis if the ability of the operator is questionable. Ano ba itong mga nandito? Okay, we have here the this one. Okay, uh, this is the dental microscope. Okay, sorry, this one. Ito yung dental microscope. Okay? And this shows how it is used by a single operator. And, okay, this now demonstrates how it is used by both surgeon and the assistant. Okay? And between the comparison between surgical handpiece with a standard size head, okay, and a surgical handpiece with a miniature head. Okay. Before I forget, anong difference ngayon ng surgical handpiece compared to a conventional handpiece?
No,
When you
excuse
see,
po,
yes.
pa-admit daw po si Miss Alcuin po.
Okay, thank you. So going back to our discussion, what is the difference between surgical handpiece and conventional handpiece? So a surgical handpiece has vents. So this will now allow the air that drives the motor, that drives the bearing to rotate, to go back, or nagkakaroon ng retrograde backflow of air. So the air doesn't come out, it doesn't come out of the head. Instead, it goes at the back where the vents are. So it will only be the water that comes out from the head of the handpiece. So anong purpose? What do we get from using surgical handpiece? Dok, pwede naman gamitin yung conventional. So the advantage of using surgical handpiece is we can avoid or prevent the influx of air into interstitial spaces of tissues, which is called emphysema. Okay? And this is a complication of surgery wherein if there will be emphysema, definitely patient would experience a crackling sound or it's like a crepitus. So pag pinalpate mo yung swelling with the discoloration, and you might get mistaken by looking at the emphysema na baka ang isipin nyo hematoma. So the difference between emphysema and hematoma is the location. So emphysema is away from the surgical site and hematoma is towards the surgical site. Okay. So we go now to the next slide. Okay. So as I was saying, surgical emphysema or the influx of air, the introduction of air into soft tissues. So this is a very acute onset or this is rapid onset. So it develops within seconds or minutes. Okay. And although this may resolve in 3 to 10 days because the air is resorbed into the bloodstream and then eventually being secreted via the lungs. Okay. So, but the spread of large amounts of air can enter the deeper spaces and these can cause serious complications. Okay? And emergency intervention is required in severe cases and with the evidence of airway compromise or and also dysphagia. So, tingnan nyo ngayon tong infraorbital ng pasyente natin. Okay? That is a surgical emphysema below the eye. Diba? And at the center, okay? At the center, yan. Isang pasyente lang yan eh. Yan. So, isang pasyente lang yan nasa kanan natin. So, surgical emphysema now involving the right eye. Okay? Including the significant buccal and palpebral swelling was also evident immediately after closure of the surgical wound with sutures. Okay? And the last picture here with the covered eyes, and that is the total resolution of the surgical emphysema. Although no medications were given and post-operative recovery was uneventful. And these are now the armamentarium. So these pictures showing now the comparison of standard sizes instruments and the microsurgical instruments. Okay? So tingnan niyo yung standard, yun yung mga nasa left side. And then yung mga microsurgical, yun yung mga nasa right side. Let's begin or start with the mouth mirror. So imagine like a comparison of a standard number 5 mouth mirror compared to microsurgical mirrors or the micro mirrors, which may be rectangular, okay, or even round. So yung round na yan, ang measurement niyan is 5 millimeters in diameter. And this is for the visibility of the apical preparation. Okay? So we go now here to the blades. Okay? The comparison between a standard scalpel with a 15C blade and a micro scalpel, which can be used as either a straight blade or as an angulated blade by bending it with a needle holder until the desired angle is achieved. And the next one is the surgical these are periosteal elevators. So the leftmost, to, okay, yan yung standard na periosteal elevator, and compared to two microsurgical periosteal elevators. Okay? And these two, the last two, yan, yung dalawang nasa pinaka-rightmost. Okay? So those are tissue forceps. Okay? So tignan niyo yung tip. Although it's almost or quite similar, but the tips are different because of their sizes. So definitely the microsurgical tissue forceps has smaller tips. Okay. Ito naman yung pinaka nasa leftmost, no. These are Rubenstein retractors, which are flat, diba? With a handle. And then, tingnan nyo ngayon tong iris scissors. Okay? And this is a standard iris scissors, yung left side. At yung nasa kanan, yun yung microsurgical scissors. And the other photo here,
Yes po, Doc.
okay. Sige. After every slide, mag-ano lang. So, going back, no, the needle holders now compared to standard needle holder and the microsurgical needle holders, and you can see that's the size discrepancy. Mas malapad yung standard compared sa mga microsurgical needle holders. Okay? So, next slide. Can you hear me?
Apo, Doc.
Thank you. So, these are the ultrasonic tips or the ultrasonic retro tips, which are designed to prepare the root and cavities. And this is to remove the debris, but it produces a smaller diameter cavity. Okay? So, yun yung mga tips na nasa left side nyo. Yung dalawang parang needle, okay? These are MTA carriers. Okay? Both are syringe type carriers, but they are designed by different companies. So let's talk about the indications. So when you look at this case, these are indicated for surgical endodontics. Why? Because of the periradicular radiolucency or pathology that surrounds the root canal treated maxillary left central incisor. Naman tayo sa molar, okay? This case has persistent pain because of overfilling of the canals of this molar. And then if we know the indication, okay, we should so meron pa indication dito. Okay. Yan. So these are also indicated for surgical endodontics. The perforation of the root due to improper placement of posts. Nakita nyo ba yun sa post na yun? And then yung radiolucency now surrounding or around the apices of the molar, the mandibular molar. Okay? So yan yung mga pwede nating gawin na surgical endodontics. What about the contraindication? Okay? May tinatawag tayong dental factors like poor periodontal support or the patient has active periodontal disease. Okay? So, tingnan nyo tong nasa left photo. Okay? So, there is absence of bone on the bifurcation area. So, wag mo nang i-surgical endo yan. Bunutin mo na yan. Okay, another contraindication. So, here, we can say that there is also patient factor, specifically systemic medical conditions or the underlying medical conditions of the patient. So we need to consider this. And this case, yung nasa baba, yung nasa right side, this is a case of a geriatric patients which can be challenging because of the likelihood of sclerosed root canal system. Okay? Nakita niyo ba yung sclerosed root canal system masyadong constricted, masyadong halos wala ka nang makita. Okay? So, ang treatment dito, ang ginawa, inexo na lang. And you can see now that the tooth extracted has a vertical fracture. Can you still hear me?
Doc, pa-admit daw po.
Okay.
Thank you po.
Can you see my screen?
Yes po.
Okay. So we go now to meron na, nasa contraindication na tayo. Another contraindication is the cases which has anatomic factors. Okay? Pag sinabing anatomic factors, ito yung mga maxillary sinus, o kaya yung nasal floor, the inferior alveolar nerve, the mental foramen. Okay? So, tingnan nyo tong x-ray na to and the CBCT. This is from the same patient. Okay? So, the x-ray shows now radiolucency on tooth number 35. Diba? So, mayroong large radiolucent area. And this is caused by fractured file fragment on the apical portion of the tooth. And this tooth number 35, when you look at it in CT scan, okay, so makikita nyo yung close proximity ng sa rightmost picture tayo, yung right picture tayo, makikita nyo yung close proximity of the apex to the mental foramen. So this indicates now that there is a high risk that the mental foramen could be damaged if you proceed with your surgery. So instead, the tooth was extracted. Okay. So we go to problematic cases, no? So here are some of the problematic cases. If you look at the X-ray on the left side, okay? So the X-ray on the left side showing apical curvature on the mandibular second premolar, and surgery was performed to resolve persistent apical periodontitis. Okay? So, apical perio. O, tignan nyo ngayon yung nasa gitna, yung clinical case. Okay? Yung clinical case ngayon, the gutta-percha has been extruded into the submucosal tissue. So, periapical surgery was required to remove the excess and also to ensure that the root end is filled. And this usually happens kapag yung ginamit yung filling material ay paste type. Okay? Paste type. So, depending on the case, sometimes we need to consider bone grafting or membrane grafting. Okay? So, the right photo now, another case of an overfill of endodontic material which already came out to the apex. And this case was even aggravated by the presence of impacted third molar, which is the tooth number 38. Can you hear me?
Yes po, Doc.
Thank you. Okay. All photos here are the same patient. Okay?
Yes.
Tingnan nyo ngayon yung pinaka left photo. There is a broken endodontic instrument. So it is lodged on the apical third of the distal root. and it also impinges the mandibular canal. And then when you look at it in the CT scan, there is 1.4 millimeter distance between the broken instrument and the mandibular canal. Imagine 1.4 millimeter. So, the tooth was extracted and apicectomy was done on both roots with retrograde MTA, and then the extraoral dry time was even less than 5 minutes. So, nagawa na lahat yon, and then the tooth was re-implanted and sutured into place. So, post-operative, nakita nyo ba yung pinakakanan sa rightmost? That is 1 year post-op showing satisfactory healing. The case is asymptomatic and there is no evidence of resorption. Yan. So another case of problematic scenarios. Okay. Yan. A large ZOE sealer overfilling. But this case or this scenario was tolerated by the patient for many years. So, asymptomatic siya for the longest time. And this is miraculously unbelievable because there is no neurovascular involvement in this situation. Okay? So, doon tayo sa isang case ulit, yung may A and B. Okay? So, yung A, there is an inadvertent extrusion of the gutta percha through the apical foramen. Diba? During obturation yan. And then, 6 months re-evaluation now, yun sa B na tayo, there's normal healing despite the presence of the extruded material. Diba? Kita nyo, may bone deposition pa nga eh. So, if the apical foramen is clean, very well sealed, lesion will heal around the extruded material. And the best post-op course is re-evaluation in 6 to 12 months. Okay? Ganyan natin sila nire-recall. Okay. Can you follow? Can you
Yes
follow?
po, Doc.
Thank
Yes
you.
po.
All right. So I will show you now a specific case to illustrate the general steps in surgical endodontic procedure. Okay? So we have here an extensive periapical lesion. Nakikita nyo ba yung mga arrow sa x-ray? Involving the maxillary right lateral incisor. So tooth number 1, 2. Okay? Our clinical picture or photo of the case pointing at the possible location. Okay? The possible location of the lesion which is based on the radiograph. And there is no clinical evidence of the lesion. So clinically, hindi mo makikita. So nasa loob, pero according to the radiograph, there is radiolucency already. Okay? So mag-a-anesthesia tayo. Okay? Yan yung unang gagawin. I'll show you it. Yan. Okay? I'll skip the number 1 kasi infraorbital yan pero mahirap nyo yan. Sa gitna tayo, yung pinakagitna. Number 2 is the nasopalatin block. Number 3 is anterior superior alveolar nerve block. Number 4, the middle superior alveolar nerve block. Number 5, posterior superior or the PSAN. And then number 6, the greater palatin nerve block. Okay, doon naman tayo sa lower. Letter A, long buccal nerve. B, ian. C, mental. Okay? So, we go now to the flap design, which is the management of soft tissue. So, I think there is a missing eye in the tissues for the management of soft tissue in your notes, in your handouts, in your books. Paki-correct na lang. Okay? If na-correct na, just leave it. Okay. So, ito na tayo ngayon sa flap design. So, the diagram here on the left, And the other one is the clinical. It shows now the creation of trapezoidal flap. So the incision goes around the gingival margin of the involved teeth, and it terminates now with double vertical releasing incisions that are divergent or that are oblique on both ends, resulting in a broad-based flap. Following the principles of flap design, the base should always be wider than the apex. That is one of the principles. Okay. Next is the uh, next is the okay, wait lang. Can you hear me?
Yes po, Doc.
Thank you. The reflection now of the mucoperiosum and the exposure of the labial alveolar cortical plate using our periosteal elevator. And after elevating the flap, we now retract the flap by using our Seldin retractors or Minnesota retractors. Okay. Meron ako ipapakita sa inyo dito. No? This is not part of our case involving the tooth number 1, 2. But since we have discussed flap designs from our previous lectures, so these are other flap designs that has not been discussed before. So this is what we call submarginal flap or the Oxenbein look flap, which is on page 188 of your notes. So this is only utilized for maxillary teeth if crowns and bridges are involved. Okay, yung naka-X dyan, yan yung ipin na kailangan natin i-endo. Okay? So, look at the top photos. Yun dalawang nasa taas. And yung dalawang nasa taas, that illustrates the flap design where the scallop horizontal incision is 3 to 4 millimeters away from the gingival margin. So, iniwasan niya yung gingival margin because of the crowns. Kasi pag dinamay mo yun, baka magpalit ka pa ng crown since magkakaroon ka ngayon ng gingival resorption. So, let's go now to the A, B, C, and D. Okay? So, A, incision line that shows the case that involves 3 teeth. The maxillary right lateral incisor, canine, and the first premolar. And then the flap reflection using periosteal elevator, that is B. At yung letter C, okay, that is already the flap retraction. At yung letter D, that is the periapical radiograph of our additional case. So balik na tayo ha. Back to our case that we are discussing. Okay? So, ostectomy na tayo. Ostectomy. Okay, ostectomy. So, ostectomy is the surgical removal of bone or a piece of bone. Yan. So, our diagram here on the left side and also the right image, they show the creation of osseous window or what we call the bony window. Okay? So the bone covering the root tip is removed peripherally with a round burr, okay, with a steady stream of water as for our irrigation or with normal saline solution. And then if the lesion is large, mas malaki din yung opening. Because remember, our goal, okay, is to remove the entire lesion. Kaya pag nag-osteotomy tayo, nagbo-bone window tayo, depende yan sa laki ng lesion. Pero hindi naman pwedeng sobrang laki din kapag sobrang laki na yung lesion. Kasi, mauubos naman yung bone structure. Okay. Can you still hear me?
Yes po, Doc.
Thank you. Okay, our diagram now on the left side and also the clinical picture, okay, showing curettage. When you say curettage, this is the scraping of the remnants or the debris around the entire periphery of the cavity. So it's not just around the periphery but also includes the adjacent bone or the bony crypt. Okay? And the periapical curette and also sometimes hemostat, no, ginagamit din tong hemostat, may be used to remove the pathological tissue, what we call the granulation tissue, or any foreign material or any excess filling material in the periapical region of the apex. And some pathological tissues may be located behind the apex. So imagine, challenging yung pagtanggal niya itong mga to. Okay? Ang sakit din sa kamay kasi kinakayod mo ng kinakayod. And the lesion or the tissue is sent for histopathologic examination. Okay? And which is the reason all attempts must be made to remove the lesion in one piece. Kasi nga, this will aid the pathologist to arrive at a proper diagnosis. And then, may container yan, may fixative, and then meron yang identity nung specimen or yung patient information. Okay, here comes now the apicoectomy or the apical surgery, the root end resection, the root end surgery. It means it is the cutting or the resection or the amputation of the apical portion of the root, around 3 to 4 millimeters. So what do we use here? So we make use of our tapered fissure burr, okay, to make the apicoectomy cut, and then curettage now can be done on the newly exposed periapical region behind the surrounding the root apex. Okay? Kasi natanggal mo na yung apex, so pwede mo na i-curate yung likod. And then irrigation with NSS, okay, to dislodge the remnants of the pathological tissues. Are you still with me?
Yes po, Doc.
Yes po, Doc.
Thank you so much. And here is now the angulation. Okay? Meron tayong angulation, di ba? Angulation yan or the yung bevel ng cut natin sa apex. Yung letter A, okay, which has 0 degree. Okay? A is just a baseline. Hindi yan yung cut natin, ha? Yung violet. Baseline lang yan. To show comparison na pag straight line yan, ito ang mangyayari. Tingnan nyo ngayon yung letter B. Yung blue. Okay? And this is the general rule for bevel angle. Okay? So, cutting the following the modern technique which is 10 degrees. Okay, wherein the resected root end is almost perpendicular to the root. Yan yung 10 degrees. Letter C. The general rule for bevel angle of the cut following now the traditional technique which is 45 degrees. So yung modern, yung 10 degrees, yung letter B, yung traditional, yung 45 degrees. Okay? So ano na ba ang sinusunod ngayon? Yung modern. Okay? Kumpara nyo doon sa isang illustration ngayon, yung letter B, this is the modern technique. Okay? So, it results now to less dentin involvement but inadequate direct visualization of the resected tooth. Compared to letter C, this is the traditional technique. Okay, results to a more dentin involvement but adequate visualization is possible. So, ano bang ginagawa? Ako, dati, doon ako sa C. Ngayon, B na ako. Okay, kasi nga yun na yung modern. Okay, ito yung mga... Although our case that we are discussing did not use this, these are methylene blue dye. Okay? So, dinaday ito. Ginagamit to dye to the resected root tip for around 10 to 15 seconds. Okay? And the application of this is around 10 to 15 seconds. So, stain resected root tip after a thorough rinsing and also drying will be now viewed directly and indirectly through a rectangular micro mirror. Yun yung diniscuss natin kanina. Okay, ito na ngayon yung retrograde cavity preparation. Okay, ito yung methylene blue. Ito yung pag-prepare ng cavity. Okay? So back to our case. The retrograde cavity preparation is the preparation of a small cavity now on the resected root end because this can accommodate a retrograde filling material. So look at the diagram now. It shows the traditional technique. Diba? Traditional technique yan. So, yung nasa ba? Yung una. Samantalang yung pangalawa, yung may malaking butas, that is a modern technique. A modern technique. Okay, ito na tayo. This is the retrograde preparation. So ideally, retrograde cavity preparation is a class 1 cavity prep with a depth of around 2 to 3 millimeters into the root dentine. And then the cavity walls should be parallel with the anatomic outline of the root canal space. And there must be adequate retention for the root filling material. Para kang nag-class 1. This is now the temporary obturation, okay, of the bony cavity. So, tingnan niyo yung picture natin, yung illustration tsaka yung picture sa may left side. So, bleeding in the bony crypt must first be controlled before attempting to place the retrograde filling material. Okay? And that is very essential. Kasi, in case of breach in the maxillary sinus lining, the temporary obturation now or the packing will prevent the ingress of foreign material into the antrum. And tingnan nyo ngayon yung illustration sa right side, a suitable packing material like bone wax or gauze, okay, is packed directly to the surface of the bony crypt. Okay? Over gauze, since gauze can easily be displaced because it does not adhere to the bone compared to bone wax. Okay, paano ba yung bone wax? Ayan, ganyan yung bone wax. Okay? Ganyan ang itsura ng bone wax natin. Bone wax is readily available in sticks or plates. It is hydrophobic. It appears like opaque or whitish yellow material. Okay? But all traces must be removed after placing the retrograde filling. And this bone wax is also malleable. It is warm. It is soft. So, pwedeng i-mold ng daliri natin yan. Okay?
Doc, excuse
Okay.
po.
Yes?
Admit daw po.
Okay. Thank you.
Thank you po.
Okay. So, this is now the placement of retrograde filling material. So, before, we use amalgam filling. Pero ngayon, ang ginagamit na natin, MTA. Okay? And then once the root end has been irrigated, dried, and then moist-free na siya, so doon natin ilalagay yung retrograde filling material natin. And, syempre yung carrier, di ba? Tapos kina-carve natin ng Hollenbach carver or any carver. Okay? So, yung syringe type na pinakita ko sa inyo kanina, yun yung gagamitin to transfer now the filling material. Can you hear me?
Yes po, Doc.
Yes po,
Thank
Doc.
you. Salamat. So, here is now placement of retrograde filling material. And burnisher is used to pack and compress the retrograde filling material until the material has initially set. Okay? Initially set. Okay, yan. So, makikita nyo ngayon yung bony cavity or bony window natin. So, any excess material may be removed with a carver or curette. Okay? And a carbide burr may be used to smoothen, to polish the material. Remember, ang tigas ng MTA, di ba? So that is the temporary obturation material, and then it may be removed after this procedure. Okay? A confirmatory radiograph may be taken bago nyo tanggalin yung temporary obturator. This is to ensure the correct placement of retrograde filling material, and it will also verify that the root apex has been completely removed and sealed. And the temporary obturator is removed when no retrograde filling material has to be added. Okay, yan yung MTA. Okay? And can you hear me?
Yes,
Yes.
po, Doc.
Yan yung MTA. And the aim of our retrograde filling material is to ensure, di ba, adequate occlusion of the root canal apically. Alam nyo, many materials may be used as retrograde filling material. Nandiyan yun sa handouts nyo, nandiyan sa, sa notes nyo. Though, MTA is expensive, okay? Mga bioceramic material. MTA is also called mineral trioxide aggregate. And this remains as the gold standard and the current material of choice for root and filling material. Okay? May dalawang kulay, white and gray. The main difference is its composition. So, kaya siya naging, kasi nga may ferrous, meron siyang iron oxide or ferrous oxide. Kaya, may kulay. Okay? Yung kulay gray. And yung kulay white, there's a low concentration of the ferrous oxide. So usually, ginagamit, okay, yung white para sa anterior teeth, yung gray para sa posterior teeth. Can you hear me?
Yes po, Doc.
Yes po.
Okay, kasi baka maputol na yung connection. Okay, balik lang agad. So this is now the flap reapproximation and the placement of suture. And then, tingnan nyo sa radiograph. Although the radiolucency is still there, okay, this is immediately post-op eh. Pero you can see now the root canal treatment together with the apex seal. Yun yung MTA na nilagay natin. Okay? So our post-operative care, okay, immediately starts after once sutures are in place, and then the mouth is clean, okay, and yung moist gauze should be placed on the surgical area after suture placement. So tapos pagpahingayin nyo muna yung, are you still here?
Yes po, Doc.
Okay. So, pagpahingayin nyo muna yung pasyente para before you dismiss. And then, the use of antibiotics is not mandatory. Okay? Unless the patient is medically compromised. And then, check for bleeding points on the surgical area for about 30 minutes. This will ensure sufficient clotting of blood. And then 6 months ang waiting period, okay, after the surgical endodontic procedure before you can fabricate crowns and bridges. Okay? And don't forget to give the post-op instructions both verbally and in written form. Okay. For sutures, are you here?
Yes po.
Yes po.
Okay. So, thank you. 5 to 7 days after surgery is considered sufficient for cases that use a non-surgical, non-absorbable sutures. Yung hindi natutunaw, tatanggalin na natin yan. Okay? And at the same time, tatanggalin mo at i-check mo na rin yung pasyente, not just for suture removal. Hindi yun ang totoong pakay. Ang totoong pakay natin is to check on the patient for normal healing process. Nagkataon lang na we need to remove the absorbable suture within 5 to 7 days. Pero kung wala kang tatanggalin na suture, you can make your recall or check-up in 7 to 10 days. Still here?
Yes po, Doc.
Okay, thank you. So, the following photos here now are not the same patient, okay? Not the same case. This is just used to discuss the steps of the surgical endodontic procedure earlier. So completing the entire procedure is not enough because these are some conditions that you should be on the lookout for. Okay? These can appear after or during a surgical endodontic procedure. So in case when a radiograph was taken before surgical wound closure. So there is wound dehiscence that you see in the left picture. Okay, wound dehiscence yun. As a result of